we are going to finish up with the small intestine and move on to the large intestine, and then we will be done with the GI tract. We know that the stomach is going to release acidic chyme into the duodenum. That chyme contains partially digested carbs and proteins and undigested fats. That material will stay in the small intestine sort of 3 to 6 hours-ish, depending on its components. During that time, most of the water in the chyme is going to be absorbed, and virtually all of the nutrients are absorbed. The small intestine has absolutely positively no role in either ingestion or defecation, nor does the stomach. People want to tell me that it's all the small intestine and the stomach are all about ingestion and defecation. They are not. So remember that. We've already gone over this, but let's review this again. We know that chyme enters the small intestine. We know that the liver will produce a bile, which will be stored in the gallbladder and released when you eat a fatty meal. We know that the pancreas will secrete bicarbonate ions to neutralize the acidic chyme coming out of the stomach. And it will also produce and secrete enzymes for chemical digestion. You also need mixing to occur because you need to add all of that good stuff, bile enzymes, bicarbonate ions, into the chyme. We have discussed segmentation and peristalsis in earlier sections of the GI tract and elsewhere. The most common motion of the small intestine is segmentation. And that is because you need to mix the material in the small intestine with all of the secretions of the small intestine. And you also need to move that material down towards the ileocecal valve. The intensity of that segmentation, which is basically like clumping up that material and sort of mixing it around, will be affected by both by reflexes, sometimes short, sometimes long, hormones, and nervous sympathetic or autonomic nervous system activities. Parasympathetic means you will have more digestion. Sympathetic means you will have less digestion. And as you sort of enter what's known as the fasting phase, after the material has moved down towards the distal end of the small intestine, that segmentation will start to drop off, the rate will drop off. You already know about peristalsis, and basically what you're doing with peristalsis is moving the remnants of the chyme, whatever bacteria is left and whatever debris is left, down towards the small intestine. And peristalsis, when normal, will move the material from the duodenum to the ileum in about 2 hours. At the distal end of the small intestine is the ileocecal valve, or sphincter. When it opens or relaxes, chyme will move into the large intestine by what's known as the gastroileal reflex. Gastrin will increase the motility of the ileum. And then when chyme starts to exert backward pressure once it's in the large intestine, the ileocecal valve will close. And that's going to be important because you need to prevent regurgitation back into the ileum, because you don't want bacteria from the large intestine getting back up into the small intestine. Now, large intestine is actually a really cool organ. Again, it has a larger diameter than the small intestine, hence its name large. has a number of unique features, which include the Taenia coli, which are going to be 3 bands of longitudinal smooth muscle, haustra, which are these sort of pocket-like sacs, which are formed by the Taenia coli, and what are known as epiploic appendages, which are fat-filled pouches of the visceral peritoneum. In order, the sections of the large intestine are the cecum, you have the vermiform appendix hanging off of that, the colon, the rectum, and the anal canal. And the colon will be divided into other sections itself. So let's talk about them. Locate the ileocecal valve, which is sort of just up from the lower left-hand corner. The cecum is that blind end to which the appendix attaches. Cecum leads to the ascending colon. At the upper right portion of the large intestine, you will have the hepatic flexure, which leads to the transverse colon, and then you will have a downturn, which is known as the splenic flexure, which leads to the descending colon, which morphs into the sigmoid colon, which in turn will lead to the rectum and then to the anal canal. Here are the functions of the large intestine. Please note that the main function is the production, storage, and elimination of fecal matter. That is one function. That is not 3 functions. So if you see on an exam or an assessment or a homework question, you have 3 functions of the large intestine. 1 is not production of fecal matter, 2, storage of fecal matter, 3, elimination of fecal matter. That is one function: production, storage, and elimination of fecal matter. In addition, you will have absorption of whatever remaining water and electrolytes is left in the chyme after it enters the large intestine. Further, the normal flora in the large intestine are going to be crucial because they will synthesize a number of vitamins, including K and B12. You will remember that you need intrinsic factor that is secreted in the stomach for absorption of B12, and B12 itself will actually be absorbed in the small intestine. So I would know that if I were you. Let's go over that so you can sit up and take notes, because as soon as I say that, I'm hoping you do take note. B12 will be synthesized in the large intestine. In order to absorb B12, you need intrinsic factor, which is produced in the stomach. In order to absorb B12, you need intrinsic factor, and that absorption will occur in the small intestine. We already talked about the subdivisions of the large intestine, but here we go again. Cecum is the first part. It's sort of this blind pouch to which the appendix is attached. The appendix used to be thought as sort of a vestigial structure that nobody really needed or knew what the function was, but it actually holds a whole bunch of lymphoid tissue, and it is part of gut-associated lymphatic tissue. It is a storage space for bacteria, your normal flora, and will recolonize your large intestine if your normal flora starts to die out. If it gets twisted, that as enteric bacteria accumulate, multiply, and you will end up, or might end up, with appendicitis, which needs surgical intervention. The colon itself is retroperitoneal, except for the transverse and sigmoid colons. Again, ascending colon leads to the right hepatic flexure, leads to the transverse colon, leads to the splenic flexure on the left, which leads to the descending colon, which leads to the sigmoid colon, which leads to the rectum, and then the anal canal. The rectum actually has 3 rectal valves, 2 stop feces being passed with gas. Fancy name for that is flatus. The anal canal is the last segment of the large intestine, is going to open out to the body through the anus. You have two sets of sphincters that are going to help control the movement of fecal matter. One is internal, one is external. The external anal sphincter is skeletal muscle, and at least theoretically, you do have voluntary control over that. When it comes to the histology and microscopic anatomy, you're going to have simple columnar epithelial cells, except in the anal canal, where you're going to need stratified squamous epithelium in order to withstand the abrasion of the fecal matter. There are no circular folds, no villi, no digestive secretions. You will have what are known as crypts, which will have a lot of goblet cells because you will need mucus in order to help lubricate the movement of material through the large intestine. If you end up with hemorrhoids, or if you have hemorrhoids or know someone who has them, it is because there are going to be these quite superficial venous plexuses around the anal canal, and when they become inflamed, you end up with hemorrhoids. Bacterial flora, oh, I could wax eloquent about these for classes and classes and classes. How do they get there? They're going to either enter from the small intestine or through the anus, and their job is to colonize the colon. They are going to synthesize B vitamins, not just B12, but multiple B vitamins, as well as vitamin K. You need K for clotting, and you need B vitamins as cofactors and coenzymes. They will metabolize some host-derived molecules, mucin, heparin, hyaluronic acid for joints. They ferment carbohydrates, which you have not been able to digest, and hence, that's the reason you become gassy. And they're going to release those irritating acids and gases about 500 milliliters per day, and generally you're not even aware of it. We have over 1,000 species of normal bacteria in the large intestine, and they are prevented from getting past the mucosa because there are dendritic cells within the mucosa which kind of sample the antigens of the microbes and will present T cells of mucosal-associated lymphatic tissue. You will have an antibody-mediated response, specifically IgA, which will help restrict any potential invasion of microbes. Residue from that time that left the small intestine will be in the large intestine 12, maybe 24 hours. There is no food breakdown except by your enteric bacteria, and they actually break down about 10% of the material in your large intestine. We know that there are some vitamins that are synthesized there by the bacterial flora. Water and electrolytes, especially sodium and chlorine, will be, or chloride, excuse me, will be pulled back into the body. And its major functions will be production, storage, and elimination of fecal matter. Colon is not essential for life. So the motility of the large intestine are going to be through what are known as haustral contractions, which are these slow segmenting movements. And the haustra will sort of sequentially contract in response to distension as they fill. There is a gastrocolic reflex, which is going to be triggered by presence of food all the way back up in the stomach. And that will cause or activate sort of these very slow, powerful peristaltic waves, which are known as mass movements, in order to move the fecal matter along your colon. If you have a low fiber diet, that sort of over the long run leads to a narrow colon, which leads to strong contractions, which leads to increased pressure on the walls, which may cause these herniations of the mucosa known as diverticula. Diverticulosis is commonly in the sigmoid colon, affects about half people half the people that are 70 years or older. And diverticulitis is a dangerous form of diverticulosis because the diverticula become inflamed and they actually may rupture and leak into the abdomen and be life-threatening. You might end up with peritonitis. IBS is a functional GI disorder. You're going to end up with recurring abdominal pain, stool changes. Sometimes you get bloated. You might be flatulent. You might have nausea. It can lead to depression because it can be quite uncomfortable. And it's frequently triggered by stress. So managing stress is an important aspect of treatment. Defecation, again, we talked about those mass movements, which are going to force fecal matter down towards the rectum. The distension of the rectum will trigger a defecation reflex, and parasympathetic signals will stimulate the contraction of both the sigmoid colon and the rectum, which will in turn relax the internal anal sphincter. And again, we do have skeletal muscle in the external anal sphincter, so theoretically you have conscious control of that, which will allow relaxation of that sphincter so you can defecate. In our next section, we move on to digestion of the various micro or macromolecules.